All right, today we're going to jump into a fantastic clinical puzzle. It's one of those classic conundrums. You've got a patient with low potassium and metabolic alkalosis, but their blood pressure is totally normal, which you wouldn't expect. It's a mystery that all comes down to just two simple urine tests. Let's crack this case together.
Okay, let's dive right in. So we have a patient and their labs show low potassium, that's hypokalemia, and high bicarbonate. Now that high bicarb tells us their blood is too alkaline, which we call metabolic alkalosis. Now usually when you see those two things together, you're thinking, okay, high blood pressure. But here's the twist, their blood pressure is perfectly normal. And that right there, that's our starting puzzle.
So we're looking at this really contradictory picture, right? The labs are screaming one thing, but that normal blood pressure just throws a huge wrench in the works. To solve this, that very first step you take, the first test you order, is absolutely crucial. So, where do you start?
Well, our first and honestly most critical move is to check the patient's urine. It sounds simple, but this single analysis is going to act like a fork in the road. It's going to split our list of possible diagnoses into two completely different pathways.
And the key test we're talking about is the urine chloride level. It's a super simple measurement, but it tells us this profound story about what the kidneys are up to. See, a low level, less than 20, tells us the body is desperately trying to hang on to volume. This means the condition is likely chloride responsive, and it'll get better with saline. But a high level, that suggests the problem is the kidney itself. It's just dumping chloride, making the condition chloride resistant. And just like that, this one test gives us our first huge clue. If the urine chloride is low, we've got a really clear path forward. But if it's high, well, the puzzle just got a whole lot more interesting, and we've got to dig a little deeper.
You know, to make this really concrete, let's not just talk about one patient. Let's imagine 3 different people. And all 3 of them walk into the clinic with those exact same initial labs: low potassium, metabolic alkalosis, and totally normal blood pressure.
So here are our 3 patients. We've just run our first big test, the urine chloride. And you can see right away patient A stands out. Low urine chloride, they're going to respond to saline. But take a look at patients B and C. Based on this test alone, they're identical. For patient A, the case is pretty much solved. That low urine chloride points us straight to a chloride-responsive cause. And the most common reasons for that? Losing a bunch of stomach acid from something like vomiting or maybe an NG tube. We give them some saline, their volume gets better, the alkalosis corrects itself. Case closed. So that leaves us with patients B and C. They're both losing chloride in their urine, giving them this chloride-resistant alkalosis. On paper, they look exactly the same so far. We absolutely need another clue to figure out what's really going on with each of them.
All right, it is time for our tiebreaker test. This next clue is going to beautifully separate these two cases because it's going to reveal the very distinct underlying genetic issue in each patient.
That's right. We are going back to the urine, but this time we're looking at calcium. And this simple test is going to reveal everything we need to know. It exposes exactly how each patient's kidneys are handling calcium, which it turns out is directly linked to their core problem.
And would you look at that? The difference is just dramatic. Patient B is losing a ton of calcium in their urine, while patient C is hanging on to it for dear life. This, right here, is our aha moment. We have all the clues we need. Patient A is already solved, so now it's time to unmask the final 2 diagnoses for patients B and C. So for patient B, that combination of high urine chloride and high urine calcium, what we call hypercalciuria, points us directly to a diagnosis of Bartter syndrome.
And here's why that happens. In Bartter syndrome, the problem is deep in a part of the kidney called the thick ascending limb. There's a key transporter here. It's called NKCC2, and it's basically broken. Because it can't pull salt back in properly, it leads to salt wasting. This also messes up the electrical gradient that's needed for calcium to be reabsorbed, so the kidney ends up losing both salt and calcium in the urine.
Now on to patient C. High urine chloride, but very, very low urine calcium, or hypocalciuria. This is the absolute classic signature of Gittleman syndrome. So here, the problem is in a totally different part of the kidney, the distal convoluted tubule, and it's a different transporter called NCC that's defective. This also causes salt loss, which is why we see the high urine chloride. But what's fascinating is that this defect has the exact opposite effect on calcium, causing the body to reabsorb it like crazy and hold on to it tightly.
So let's just put them side by side. It's really a tale of two different transporters. Bartter syndrome hits the NKCC true transporter in the thick ascending limb, and that leads to high urine calcium. Gitelman syndrome affects the NCC transporter in the distal tubule, which leads to low urine calcium and often you'll see low magnesium levels too. Two totally distinct syndromes that we could only tell apart by checking that urine calcium.
Okay, we've solved all three mysteries. Now, let's take this whole process and distill it down into a powerful, simple blueprint that you can use anytime you run into this clinical puzzle.
Let's wrap this all up in a simple three-step approach. Step 1, identify the pattern: low potassium, metabolic alkalosis, normal blood pressure. Step 2, check the urine chloride. If it's low, you've probably found your answer. And step 3, if that urine chloride is high, check the urine calcium. High calcium points to Bartter's, low calcium points to Gitelman's. It's a really elegant way to navigate this diagnostic maze.
And that's exactly why this all matters. You know, as the source material points out, sometimes the answer just isn't obvious. When you're faced with a persistent, unexplained electrolyte problem, you need a rigorous framework just like this one to systematically find the right answer.
And I'll leave you with one final thought, to kind of connect this all back to everyday practice. Understanding these rare genetic diseases gives us this incredible insight into how some very, very common drugs actually work. The defect in Gitelman syndrome, for example, perfectly mimics the effect of a class of diuretics used by millions of people. Think about which one that might be. Thanks so much for joining us.